So hello, everybody, and thanks first of all to Professor Al-Ghazali and all the organizing committee and the scientific committee of this wonderful meeting for the new invitation. It's always a pleasure to be here with my colleagues. And I have the mission to discuss the, let's say, the new approaches with immuno-oncology treatments in the neoadjuvant breast cancer, and particularly in triple negative disease, what I will focus on, because we have two very, very important data that were actually published at the end of the last year. So here are my conflict of interest, and I will begin with what do we know from previous trial, and particularly in triple negative. You know, all of you, the Cortázar meta-analysis that was published in the Lancet in 2014. And here I just want to remind you what is the outcome of the triple negative disease in this meta-analysis when you just compare the pathological complete response population, the red curves, to the non-pathological complete response population, the blue one. And you see that in the meta-analysis, clearly the triple negative population might expect with the first generation trial a pathological complete response rate close to 33%. That means protocols with anthracycline and taxanes. And the second thing is that in the triple negative disease, there is clearly an overall survival benefit when you look at this meta-analysis if you have if you achieve a pathological complete response. So this was the conclusion from the meta-analysis. However, there are several points that are also very important for the triple negative disease, and particularly the neoadjuvant strategy. The first one is that we have a long-term survival outcomes in triple negative breast cancer using neoadjuvant approach. This was published very, very close to the meeting at the end of this year in Cancer Research with a network of colleagues. And you see here that this is focused on triple negative, that there is a strong correlation between achieving pathological complete response here and event-free survival in the triple negative population. And the same thing when you look at the overall survival. So they confirm what was on the Patricia Cortázar meta-analysis, but with focusing on just triple negative disease. The second thing, and this was on the annexed, I will say, tables and curves on the paper, these are the survival curves of event-free survival and overall survival derived from the meta-analysis, not only by PCR status, but also including the adjuvant therapy use, because nowadays, you know that if the patient will not achieve pathological complete response with a neoadjuvant chemotherapy, if they are triple negative, we are in the vast majority of the case proposing an adjuvant treatment with capecitabine. And they have just done the analysis and shown that not only for the event-free survival, but also for the overall survival, including the adjuvant capecitabine, might impact, again, the outcome of the patient. So there is two things. One is, of course, the optimal strategy in the neoadjuvant setting, but also the post-neoadjuvant adjuvant strategy, according to PCR, that might impact the outcome regarding the EFS and overall survival. And finally, there was in 2019 a meta-analysis just focusing on the place of platinum salt in triple negative. There are several of these meta-analyses. This one, the last one that was published, focusing also on carboplatinum and on cisplatinum, and showing that there is a benefit, there is no discussion regarding the improvement of PCR when you're integrating the platinum salts in the neoadjuvant strategy here in triple negative breast cancer. What I want just now to focus, this is not focusing on triple negative, but just to remind you the NOAA trial that was published in 2010 by Luca Gianni, focusing on HER2 positive disease. The primary endpoint of this trial was event-free survival, not PCR. And I just want to remind you that even if you have, as you see here, an improvement of PCR in the HER2 positive disease when you had trastuzumab in the neoadjuvant setting, The impact of trastuzumab regarding the event-free survival is here, regardless of achieving PCR or not, because you are continuing the targeted therapy in the adjuvant setting. And this is what you can see here in the HER2 positive population that do not receive adjuvant trastuzumab. And this, what you can see is that the outcome of this population is even worse comparing to the HER2 negative. So the conclusion from this first part is that there is a correlation between PCR and EFS, clearly. In triple negative breast cancer and HER2 positive breast cancer, it is more pronounced. There is probably a key role or an important role for alkylating agents in the neoadjuvant treatments, platinum, of course, but not only, if PCR is an endpoint. However, the validation of a new strategy increasing PCR correlated with the survival outcomes like EFS was only validated prospectively in the NOAA trial, and EFS was improved in the trastuzumab-treated population regarding of PCR. So it might be that with some treatments, EFS improvement is driven regardless of PCR. It might be amplified by the PCR increasing, but clearly out of even PCR, there is a place for some targeted treatments, even in the adjuvant setting, and even if the patient do not achieve PCR. Let's look now and focus on the immuno-oncology treatments that were used in the neoadjuvant trials. And I will focus on the two main trials that we have. The first one is the Keynote 522 study. This was published in New England Journal of Medicine very recently. And you can see here that this is a very important trial, a huge one, with a lot of patients, more than 1,000, as you see here. And there were a randomization 2:1 with carboplatinum paclitaxel, followed by doxorubicin, epirubicin, with cyclophosphamide, with or without pembrolizumab, and the carboplatinum was used weekly or every 3 weeks. Then the patient were operated, and pembrolizumab was continued in the adjuvant setting, regardless, here again, of achieving PCR or not. Stratification factors were nodal status, tumor size, and carboplatinum schedule weekly or 3 weekly. Here is the repartition of the population, and when you see the characteristics, you can see that we have pretty important number of pretty small tumors, I will say, T1, T2, and half of the population was node negative. Stage 2 was 75% of this population. However, when you look at the primary endpoint, which was a co-primary endpoint with the EFS, there is clearly an improvement of PCR, moving from 51% to 65%. And interestingly, in the analysis regarding the PD-L1 status, there is here again an improvement in the PD-L1 positive population, close to 70% of PCR, but also, and the delta was the same, even more important, in the PD-L1 negative population, when you compare the patients that were treated with and without, again, pembrolizumab. The second trial I want to focus on is the Inpatient 031. This trial was presented at the ESMO this year, and published in the Lancet some weeks before. And interestingly, it was a smallest trial, triple negative cancer, randomization 1:1. And here the patient was treated with nab-paclitaxel due to the fact that they want to avoid the corticosteroids use in combination with atezolizumab, plus nab-paclitaxel, followed by atezolizumab plus doxorubicin, or in the control arm, the same chemotherapy regimen with placebo, so without atezolizumab. Here you have the study design. The patient were operated, and then again, the patient received atezolizumab in the adjuvant setting, regardless of achieving or not PCR. The certification factors were stage 2 versus stage 3, and the PD-L1 positivity. The primary endpoint was the PCR, but let's look at the repartition of the population. And here again, you can see that we don't have T1 tumors. We have just T2, T3, and some locally advanced tumors. T2 was 70% of the population, and stage 2 was again close to 70% of the population, like in the keynote trial, which is very important. And the majority of the patient had ductal carcinoma. Interestingly, node negative was two-thirds of the population that was included on this trial. So in both trials, there is a majority or half of the population which were node negative at the time of diagnosis. When you look at the result of the inpatient 031, there is clearly an improvement, again, of the pathological complete response in the PD-L1 positive population and in the overall population. You can see here that the amount of benefit and the, I would say, hazard ratio are very close when you indirectly compare the pembrolizumab trial and the atezolizumab trial. However, there is no impact here in the PD-L1 negative population, but maybe there is a good trend, and the trial was not potentially powered to answer all of these questions. So the conclusion from the result is that there is no discussion on PCR improvement in triple negative breast cancer with immuno-oncology treatments incorporated in the neoadjuvant strategy. However, Keynote 522, PCR analysis just on subgroup of the overall population and not in all the population. It's just focused on 400 patients. And in inpatient 031, it might be that the chemotherapy regimen was considered to be suboptimal. So what could be the conclusion regarding why we need to be careful? And I will come back to several points. One is this very interesting publication in PLOS ONE in 2016 by Brian Lemon, who was, I will say, the father of the redefinition of the triple negative breast cancer. And this analysis and this publication is important because it just focuses on the fact that triple negative disease is an heterogeneous disease. So it might be that the impact of PCR and the PCR that you might achieve seems different if you are a basal or non-basal, or if you look at the basal like 1, 2, mesenchymal, or luminal androgen receptor subpopulation. So maybe the subpopulation is also a driver that might be explored to optimize the place of the immuno-oncology treatments in neoadjuvant setting. The second thing is back to the Cortázar meta-analysis. When you look at the parameters that might influence the PCR, it doesn't seem that the clinical nodal status will influence it, but tumor grade will strictly influence it. What do we have in the trials with immuno-oncology treatments in triple negative? We have different things. When you look at the keynote trial, the population that might benefit more according to the PCR rate and point are the node positive when you see here. And the regimen of the chemotherapy, particularly the carboplatinum treatment, the weekly regimen seems to be optimal and more effective. What do we have in the inpatient 031? Same signal regarding the lymph node positive disease that clearly might benefit more from the EO treatments comparing to the lymph node negative. And finally, we have a clear, I will say, strong signal of EFS, even if it's very early, of EFS improvement in the keynote trial with pembrolizumab chemotherapy. But don't forget that pembrolizumab was given in the adjuvant setting for the pembro arm, regardless of the PCR that the patient have achieved or not. So my final conclusion is that the triple negative breast cancer are heterogeneous and all the subtypes might not benefit equally from the same neoadjuvant strategy. Main clinical pathological characteristic for increasing PCR seems to be node involvement for the EO treatments. And EFS is a gold standard for changing practice and needs to be better analyzed according to PCR, particularly in the Keynote 522 trial, since it was not already analyzed in inpatient 031. I thank you very much for your attention, and I'm at your disposal to have some exchange and discussion. Thank you very much.